It's a pleasure to be here and chat about clock drawing. I'm a neuropsychologist, but this is not a neuropsych test. I kind of conceptually view it as kind of a bedside screening procedure. Neuropsych tests that we have, it's given the same way each place, lots of norms, it's scored up, and there's no confusion with respect to when you get a percentile, what it means. Like I said, this is more of a bedside screening procedure, and that means it's done differently. And I'm not here to argue for one version of scoring approach being better or worse than any other ones. And I'm going to actually try to emphasize the importance of taking a look at the clock drawing rather than just simply relying on whatever number you have, because it really provides rich qualitative information to help you better characterize and understand what a patient's cognitive impairments might be. The different approaches, like I said, I'm not going to talk about, but they're basically like the MoCA. You take a look at the circle, take a look at how the numbering is, and more or less take a look at the hands. So the question I think everybody's interested in is, when you get a clock draw, is it normal or is it not normal? And I always like to play with my students and say, well, a lot of times you can rely on my rule of thumb is specifically, if my mom looked at this, would she say this was impaired or not impaired? I think we can pretty much agree that this is not a good clock, and my mom would agree that this is not a good clock and probably reflects some sort of a cognitive impairment that might be clinically meaningful. We get situations like this, though, where it's a little bit unclear. Here's a clock. I think most people would say it's not too bad. If I asked my mom, is it okay? I think she'd probably say yes, because 10 minutes after 11, that's kind of okay. Spacing's not horribly bad, but kind of what do we make about this being in the pedestal? It's certainly odd, and I would, if you'll indulge me a little bit, call this a soft neuropsychological finding. What I'm going to talk about and show some examples of today is kind of what I call error types of clinical interest. And these were described by the Kahn-Weiner citation that I have at the bottom of the slide. I'll go over some examples of all these, but I think the thing I want to emphasize to begin with is that these are not mutually exclusive categories. And in fact, one of the reasons the clock drawing is so sensitive to impairment is it relies on many different domains. So impairment in any sort of cognitive construct is going to result in an impaired performance level. So they're not mutually exclusive. And oftentimes there's more than one of these impairments that I'm going to show you that are present when we're taking a look at the clock drawing itself. Clock drawing at least became very popular in the early 1980s, and it was, despite my talking about neuropsychology, done by a neuropsychologist at the Boston VA named Edith Kaplan. You may be familiar with her name because she was involved with the development of the Boston Diagnostic Aphasia Examination. The cookie theft card is part of the NIH stroke scale characterization. She had both a command, which is a standard clock drawing, and a copy version that kind of helped tease out some of the conceptual versus perceptual aspects when you have a bad clock draw. A number of times have been used to set the hands or to set the time of the clock. We have popular 10 minutes past 11 and 20 minutes to 4. And these are important because you take a look, both of these times involve both hemifields. And there's a little bit of confusion with respect to the difference between the number that designate the hour and the minute placement. I started actually with 20 minutes to 4, and over time have switched to 10 past 11 as kind of a preferred approach. Also, when I give the instructions, and I give it outside the context of the slums or the MoCA or anything else, I use that as a screening test that I can personally observe as part of my clinical interview. I give the instructions 3 parts. First, I ask them to draw a circle. Then I ask them to start numbering, but start with number 12 at the top, and then go around 1, 2, 3, 4, 5, and so on, and then set the time to 10 past 11. And the reason that this is important to me is other approaches, a person will probably start with the circle, then start 12, 3, 6, and 9. And what this does is it provides an anchor to the patient that can compensate in part for some poor planning that I want to test with the clock, so they can go back and then fill in the numbers. And it decreases the likelihood that I'm going to find information that is clinically meaningful. So I try to keep them from using these anchors or the corners of 12, 3, 6, and 9.